All right. So it's 12:30, so we're going to go ahead and get started today. Thank you for joining us for our South Texas Regional Family Medicine Grand Rounds. Our educational partners today are the South Central Area Health Education Center. Our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. All right. Today is April 23rd, 2025. And you can register your attendance and claim credit using the CME credit via text system. You can text attend 1009-6255 to the number on the screen to record your attendance. Again, today's code is 1009-6255. AAFP members can use your login and claim credit for this activity online at the link on the screen. In this live activity, the South Texas Regional Family Medicine Grand Rounds has been reviewed and is acceptable for up to one prescribed credit by the AAFP. Physicians should claim only the credit commensurate with the extent of their participation in the activity. The Family and Community Medicine Grand Rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. And now Dr. Opide will introduce our speaker.
All right, well, good afternoon, everyone. I have the pleasure of introducing our Grand Round speaker for today. I'm going to read her bio so I don't miss anything here. So Ray Narun, I pronounced that right, is from Philadelphia, Pennsylvania. She received her bachelor's degree from Penn State University in State College, Pennsylvania. She received her master's degree from LaSalle University, also in Philadelphia. She is working towards her doctorate in clinical psychology, also from LaSalle. Ray is currently finishing her final year of her doctoral program, is completing her internship here at UT Health San Antonio on our primary care track. Next year, Ray will be moving to San Francisco, California to serve as a postdoctoral fellow for California Pacific Medical Center. Without further ado, I'll hand the mic over to Ray.
Hello. So this presentation is going to be about psychology in cardiology, an integrated biopsychosocial approach to care. The objectives are to understand the biopsychosocial factors that impact the development of cardiovascular disease, understand how to utilize integrated care to meet best practices, and gain knowledge of some behavioral cardiology interventions that hopefully you guys can feel comfortable using with your patients. So why do we care about heart disease? It's the #1 cause of death in the United States. Almost 50% of people in the United States have some type of cardiovascular disease, and about 46.7% of all adults experience hypertension. And the cost is heavy. It's about $252.3 billion per year. This includes the cost of medical expenses and medical care services, medications, and loss of productivity due to death. And on the right side of the slide, you can see the breakdown of death based on demographics. So what is psychocardiology or cardiac psychology? It examines the interaction between psychological factors and cardiovascular health. It has a focus on the behavioral health contributions to the development, progression, and the management of heart disease. And I feel like it's important to discuss with you all because primary care clinicians are often seeing people in the early stages of the development of cardiovascular disease. And also that includes when they're young and when they start developing patterns of lifestyle, like including their eating habits, diet, exercise, things like that, that can start to contribute to the development of CVD down the road. Dr. Robert Allen is the cardiac psychologist with a cardiologist named Dr. Stephen Scheidt. And he wrote Heart and Mind with another person, Dr. Fisher. And a lot of the information in this book was taken from cardiac rehabilitation. So after people had had a major cardiac event, they would go to a cardiac rehab. A lot of those groups were very helpful for people, but they weren't accessible. So they started to develop CBT protocols and things that could be used in an outpatient setting. And it's all contained in this book. There's a lot of different types of protocols. So I wanted to look at this through a biopsychosocial lens. I think this is especially important in the case of cardiovascular care. The biomedical model primarily focuses on biological mechanisms. And if you look here, you can see that this specific graphic, it is specific to cardiovascular care. So some biological factors that would impact that would be age, sex, genetics. Down the road, you might see functional limitations and medications involved. But then you also have to consider the social aspects of cardiovascular disease. That can include lifestyle, diet, smoking, alcohol use. It can also include social isolation. It can include low SES and barriers to healthcare access and treatment adherence. This also overlaps with psychological factors like depression, anxiety, PTSD, personality type, and emotion regulation as well. And all these factors together are working to impact somebody's risk for cardiovascular disease. Some of them, hold on. There we go. Some of them will be modifiable and some of them won't be. We can't change somebody's age, gender, family history, things we don't know or things they don't share with us. But many factors, often we find in the psychological and social categories, can be modified. We can change how somebody reacts to stressors. We can help change their weight. We can help focus on diabetes management. We can help focus on hypertension management, diet, depression, and things like that. So we're going to talk about some of those factors that are modifiable. We'll talk about health behaviors, depression, anxiety, chronic stress, personality type, PTSD, and social determinants, and how this can increase someone's risk for cardiovascular disease, and also what kinds of interventions can be helpful to address them. All right, so we'll talk about the impact of stress first. The risk of cardiovascular event increases in patients that have chronic stress. This was looked at specifically in certain situational factors, like someone experiencing chronic work stress, somebody with chronic marital problems or marital separation, and individuals who have been recently diagnosed with a medical illness or are caregiving to somebody who has a medical illness. All of these increase the risk for a cardiovascular event. Socioeconomic status is considered a composite chronic psychological stressor for some of the reasons I mentioned, barriers to healthcare, but also barriers across life and how that can impact somebody's well-being overall. This creates chronic stress for somebody. Chronic stress is associated with the risk for developing hypertension. And for individuals that have adverse childhood events, they're at a 1.5 times increase in the early onset of cardiovascular events. Perceived stress level also plays a role. This is how somebody relates to their stress or how they understand their stress. So individuals who are in the same situation, who may have the same objective stress load, let's say, from that situation, may perceive that stress differently. Individuals who feel like stress is a negative driver, has a negative impact on their health, are more likely to have negative outcomes as a result of the stress. And also, social support has been demonstrated to be very important. What they found through some of those cardiac rehabs is that part of what was so helpful was being in a group setting and discussing making these lifestyle modifications and what it was like to have undergone a serious cardiovascular event. Depression is another robust area of research when it comes to psychological factors that impact cardiovascular health. You can see from the graph that is up there, individuals who are endorsing more items on the BDI are at a higher risk of mortality following a cardiovascular event. In coronary artery disease, the prevalence of depression is 20%, and this increases to 30 to 40% in patients with heart failure. Patients that have had an MI are at a 3 times greater risk of developing depression. So it's considered a bidirectional relationship. Depression causes the development and contributes to the development of CVD, but it's also a result of having experienced a major cardiovascular event. Part of this is because when someone's depressed, it impacts their health behaviors. So it impacts their treatment adherence, it impacts their motivation for dieting, exercise, lifestyle mod, things like that. Okay. It's also a predictor for adverse outcomes. So like I said, after something like the cabbage, depression is linked to poorer functioning and linked to higher rates of mortality. It's a risk for CVD hospitalization and death. It predicts poorer prognosis in HF, and for patients that have depression, they experience more ICD shocks in the preceding 2 years than those without depression. So it's highly recommended that we screen for depression using a 2-step screening protocol in cardiovascular patients. This is something we already do at our clinic using the PHQ-2, and then if items on that are endorsed, using the PHQ-9 next. Anxiety is also a contributor to the development of CVD. Patients are diagnosed with anxiety. They have a 2 times greater risk for a major adverse cardiac arrest. There's anxiety related to social stressors and minority stress that can contribute to the development of CVD. So what that means is that these stressors compile, and over time, that accumulated stress on the body can contribute to the development of CVD. It's also implicated in the development of hypertension. Individuals with anxiety are more likely to develop hypertension. People with hypertension have a 37.9% prevalence rate of an anxiety disorder. CHD event risk is also elevated among people with generalized anxiety disorders. It can be triggered as well in patients with acute coronary syndrome. So as a result of their syndrome or as a result of their illness, patients can start to develop anxiety. They may have fear of death, fear of disability, worrying about their unknown prognosis, and that occurs in 16 to 24% of patients with ACS. Personality also plays a large role. Part of Dr. Allen's research was also in anger management. Pessimism is considered a health determinant. So people's outlook on life can impact their adherence to their treatment recommendations. Pessimism also increases the risk for cardiovascular events and stroke or all-cause mortality. And what they found is that when somebody's more likely to be optimistic, this creates a buffer to some of these events. Part of this is because of anger and hostility. This was taken from widely studied type A personalities. Specific attributes of a type A personality that were studied were hostility, impatience, and time urgency. Individuals that had these characteristics were more likely to have negative health outcomes. They were at an increased risk for cardiac events. And overall higher trait level anxiety across the board is linked to worse outcomes in cardiac events. We'll talk a little bit more about why this is the case as we go through the interventions. Health behavior, of course, play a large role. So physical inactivity, poor diet, substance use or smoking, poor sleep, and inadequate rest all contribute to the development of CVD. And look at this as psychological factors. So people who are feeling more depressed, people who are feeling anxious, it's been shown that they're less likely to treatment adherence. If they have lower social support, they're also less likely to get assistance with making some of these changes, which has been considered to be a large factor. And anxiety and depression are also associated with poor health behaviors like using alcohol or smoking and drugs. This is a graph that demonstrates this. Something that Dr. Allen really reinforced in his work is that this starts with these lifestyle risk factors and the load that these have in people's health outcomes. So it starts with the poor diet, the physical inactivity, the smoking, and then it starts to move up into more of the risk factors. These things develop into obesity or metabolic dysfunction, which shows itself as hypertension, diabetes, et cetera. And then we get into the clinical endpoints of heart failure and coronary disease. But it all starts down here with people's behaviors. What are some of the reasons why these factors impact cardiovascular disease? Cortisol, hair cortisol, specifically hair cortisol levels, are associated with both the incident of cardiovascular disease and poor recovery and treatment outcomes. It's been shown that increased hair cortisol concentration has been linked with metabolic risk factors, high blood pressure, diabetes, and obesity and increased appetite. Why is this important? It can lead to inflammation, but it also leads to dysregulation in the HPA axis and changes in autonomic tone. Autonomic tone is your body's ability between the sympathetic and parasympathetic nervous system to calm your body down. The HPA axis is responsible for this process and creating homeostasis in your body. So increased autonomic tone means that overall, someone's sympathetic nervous system is more active, meaning they're experiencing more stress, more arousal. Sorry. So this leads to increased dysfunction, and that's observed as SES levels decline. So as someone's SES decreases, their dysfunction in the HPA axis increases. People who have anxiety disorders, chronic stress, and emotion dysregulation, you see the same trend as well. Another pathway that could be impacting these outcomes is the sympathetic adrenomedullary axis, or the SAM axis, or SAM axis. It's another one that links the sympathetic and adrenomedullary. And in depressed patients, we see that there's increased sympathetic tone again, and this is shown as decreased heart rate variability. It's also a contributor, or considered as one mechanism for why people might become vulnerable to arrhythmias. And this is a nice graphic that I think breaks it down really well. So it shows chronic stress and affective disorders impacting each other, and also how reactivity to stressors is inserted in to increase the HPA axis dysregulation, the arousal of the sympathetic nervous system, and possible altered behaviors to manage this. And that leads to autonomic nervous system dysfunction, insulin resistance, central obesity, hypertension, and inflammation. In patients with depression, markers for inflammation are increased as well. Stress also increases platelet activation and inflammation. This is another graphic that demonstrates what we've been talking about. So over here you have depression, psychosocial factors, environmental factors, and background factors all combining. And as you move through it, people start to have biological mechanisms like inflammation as a result, platelet activation, some of the things we were talking about like sympathetic activation. This can be in response to acute and chronic stress. It's also a result of depression. And similarly, you see people experience poor medication adherence as a result of depression, lifestyle inactivity, etc. And loneliness and social isolation can contribute to poor lifestyle behaviors. And then this develops into cardiovascular disease through these chronic risk factors, which can lead to negative outcomes. This is another graphic that I think breaks down the role of chronic stress pretty well, especially as it contributes to obesity. So if we look at this, we can see someone experiences chronic stress. They have increased cortisol levels. That makes them crave more junk food. That leads to increased fat in the abdomen, which leads to an exaggerated response to stress hormones, more cravings for junk food, worsening obesity, and then negative health outcomes like high blood pressure, diabetes. And on that next graphic, I just liked the way that it broke down the sympathetic tone versus positive vagal tone and how that's a balance for people and some of those factors that are impacted by both of those. So now we'll talk a little bit about the development of behavioral cardiology. Like I said, it started with rehabilitative cardiology. This is when patients were in those groups following a cardiac event where they were walked through a lot of education about their condition and what kinds of lifestyle changes they needed to make in order to improve their health. This was great. It was very helpful for people that could access it, but it wasn't very accessible. And that led to the development of preventative cardiology in the 1960s. People wanted to treat the CVD risk factors before people had developed CVD, and it was effective. It helped reduce risk factors. However, the primary focus was on treating cholesterol, high blood pressure, diabetes, and treating behavioral risk factors like inactivity and diet. Behavioral cardiology has worked to define the psychosocial factors that could be impacting behaviors. It's also developed practical and effective tools for promoting healthy lifestyle. However, it's underutilized. Few doctors are educated in its practice. It's not really well integrated into cardiac practices at this point, and there's little reimbursement for its application. And I put this quote up there because I like it. It's from the book, and it says, "Massive doses of traditional risk factors." And I like that because I feel like it's using it the way that we look at other medical markers. Like if people have a large load of these behaviors from a young age, they're going to develop cardiovascular issues, but I don't feel like often look at it or spend the time that we should addressing it. So these are some interventions that can be used to try to help and try to address these problems with your patients. We can foster motivation. We can use motivational interviewing. One thing to consider if you're doing motivational interviewing is the difference between us, the provider, creating motivation for our patient versus them being able to self-motivate and independently create their motivation once they leave the office and they're at home and need to do these things. We can work on increasing people's self-efficacy, but also what we can do is help people focus on present-centered benefit of health behaviors. So sure, we can say 20 years from now, if you don't change your diet, this and this will happen. But for a lot of people, that's not very urgent. So if we can find something in the present moment, like in the next 2 months, let's say, that would improve for that patient, something they could feel like maybe activity is easier for them, or if they quit smoking, their breathing starts to improve within 2 months. Finding something that they can anchor in that's more like will be closer, not 20 years from now, maybe a couple months from now, can help improve motivation. And also giving them the language through motivational interviewing, making sure that their motivation comes from them so that when they get home, they can produce that motivation independently. We can also help people set goals using SMART goals. This is good if you can get really specific with patients and help them picture what it might actually look like to add a certain behavior into their life. So if they say that they want to walk more, getting more specific with them about where, when, how, who would go with them. If you can foster social support, that's great. How would they do it if they have to drop their kid off at school and then they have work after? So helping them picture what this might actually look like. You can help encourage them to use self-monitoring to meet their goals, contingency planning, and give them ideas for how they can positively reinforce when they follow through with their goals. How can they reward themselves? Other one can be health behavior strategies, so giving a lot of diet management and counseling about diet. You can do weight loss counseling, strategies to promote physical activity, like we talked about, increase their resistance training too, outside of just cardiovascular. Like that also improves cardiovascular fitness, but outside of walking and things like that, can they add in weights? Can they do some kind of body weight workout as well to increase resistance training? And then sleep hygiene practices are important because people who have very poor sleep, they demonstrate dysregulation in the HPA axis as well, and they demonstrate higher levels of cortisol as well. And then helping people decrease smoking and substance use. We can also help patients by promoting their sense of well-being. Individuals who say they have a purpose in life often do a lot better with treatment adherence. This can be done by helping patients invest in positive relationships, getting them back involved with their church, or having them call their daughter, for example, having them practice gratitude exercises, or promoting altruism. Older adults who are altruistic or participate in volunteering efforts have better health outcomes compared to those who don't, who also in both groups have CVD. So encouraging patients to get involved in some kind of way can be helpful. We can also help with stress management because when people get really aroused and stressed, that's part of the problem, the reactivity. So we can help people with physical practices like deep breathing. That can take less than a minute to introduce to people. It's usually very effective. They usually really like it. We can also use mindful meditation and practices, help them to reframe their stress or almost use cognitive disputation for their stress, like seeing it as something that can be a driver and helpful for planning, and identify unhealthy beliefs and use cognitive disputation to change those, which leads me nicely into the next slide. We can do CBT with patients as well if they experience anxiety, depression, and in their ICD management. We can also use CBT to help with adjustment disorders. Another big one that we actually talked about recently in terms of exercise plans would be behavioral activation. Exercise plans have been proven to be great for patients with CVD and helping them get active. Again, you'd want to get really specific, and it also has been shown to improve depression as well. And increasing social support can be very helpful, especially if there's somebody who's willing to remind them of certain things they need to do or get them on board with their health. And PTSD treatment can be very helpful. So In individuals with PTSD, they're often experiencing a lot of hypervigilance and arousal when they're reminded of their trauma, when they're not able to avoid reminders of their trauma. So this makes somebody more reactive. If we can use PTSD treatment, then we can reduce cardiovascular reactivity and, in theory, improve their outcomes. And we can also use ACT to encourage engagement with values and lifestyle. So if their health is something that's really important to them, we can target that value using this treatment. This one, the hook, is specific to cardiovascular, I should say, it's specific to those CVD groups that I was talking about. It's an intervention that's derived from that. And it's really useful for that group of people that might be having some personality factors that are impacting their reactivity. So the idea is that someone is a fish, they're swimming through the sea of life, and in the sea of life, there's these really tasty baits that drop down. And oftentimes for people that fall into this category, the bait might be injustice, something's not fair, or incompetence. Somebody is being stupid or they're unqualified. And it's really tempting and you really want to take the bait. And the light bulb represents the fish going, oh, there's the bait, I see it, and just kind of swimming by. The idea is that once you get hooked, you lose your control. So you've had this big reaction. When you have a big reaction, you're often not reacting in a way that's very helpful, right? But also, what's been shown is that 2 hours after somebody has this big, angry, reactive event, they're at an increased risk for triggering an MI, and they don't have control in those next 2 hours about what's going to take place. So introducing patients to something like this to help them conceptualize how being reactive to this bait can be detrimental to their health, and that it could be better to just kind of swim past and recognize what's taking place and that it's not worth it, can be helpful for those people that might have some anger management issues, for example, or can be more hostile and reactive to certain situations. This is another one derived from Dr. Allen's work, which is reshaping resilience. In this intervention, there's multiple steps. The first one is to emphasize the danger of mismanaged psychosocial care. The goal of this intervention is to help people have more social supports and help to reinforce their natural resilience and improve it. So emphasize the danger of mismanaged psychosocial care and the importance of engaging in building resilience, and then orchestrate emotional uplifts, so opportunities to feel good. So that could be interacting with people that are social supports. That could be even like putting sticky notes that have nice words on them, places for people to see. And then providing a coping roadmap. So if there is a situation where they're feeling really depressed or stressed about their situation, about their illness, then they know exactly what they need to do to help them cope. Encourage caring connections and social support, normalize sexual concerns. This can be a big part of cardiovascular disease that doesn't get discussed, so it can be really helpful to normalize it with patients. And shape realistic expectations and heart-healthy attitudes. Let them know realistic outcomes of their care, for example, and calm fears and calm stress. So if reassurance is appropriate, then providing reassurance, but we don't want to overpromise. There are also psychosocial interventions for ICDs. The first of this treatment is to provide psychoeducation to increase people's knowledge. So you want to give them information about basic heart functioning, also information about cardiac arrhythmias, what can make them worse, for example, and be transparent about the risk for sudden death. And then you can use CBT techniques to help individuals cope with the fact that they now have this device inside of them and all the anxiety that can come up as a result of that. So you can normalize people's feelings in that context, help to restructure cognitions from I'm a victim to I'm a survivor, for example, and reduce behavioral avoidance. So sometimes people are anxious, they're not sure of what could cause sudden death or what could cause an arrhythmia, for example. So giving people information about what activities are safe versus unsafe can help them feel less anxious, and then help them with self-management of their disease and device. In this case, you want people to be aware of their symptoms and how they could monitor their device. You'd also want to give them information about what to do in the case of a recall, like if something's going on with the device and they need to contact their doctor so that they feel comfortable handling that situation, and then help them with treatment adherence. Another one is called a mindful heart. This is a psychocardiology intervention that has been practiced in primary care. It's a group intervention, but it can definitely be used. The strategies from it can be used with individual patients. It's been found to improve perceived stress, perception of physical health. It's found to improve mental health, and it's also been found to improve individuals' perception of their health overall. Some interventions from this group are psychoeducation, giving patients information about definitions, what's going on. Same with the ICD, giving them information about heart functioning, providing information about the stress response, relationship to heart disease, and informing them of behavioral modification, what it is, and reviewing it with patients. This is like the first step usually of the treatment. And then moving on to mindfulness and relaxation training to help them when they do have stress. So introducing them to something like the hook, for example, and using cognitive restructuring, responding and acting rather than just acting. So thinking about something before you do it, what's going to help you keep your cool, for example? How can you respond in a way that will improve your anxiety rather than worsen it? And then working on reducing arousal, identifying and reducing the self-destructive thoughts and behaviors and improving coping overall. These are some recommendations for providers. It's recommended, this is a recommended model of intervention. So first, you screen for depressive symptoms in patients and intervene to prevent the onset of depression. The second step would be an initial intervention for mild depression. So if somebody has a screened low on the BDI, for example, or on the PHQ-9, that could be a point of intervention right then and there to help them, because we know that even at low levels, this starts to impact treatment outcomes. You could even get one of us if you would like, and we could start with that. And then the next step is when it's recommended to have a multidisciplinary intervention when people are demonstrating moderate to severe depression symptoms. And then it moves on to specialized psychiatric treatment for people who are in the very severe range of depression. However, many practices are behind the curve of integration. Often people do not have a behavioral health expert in their practice. They're not using these strategies. They may not even screen for depression possibly. Another thing you can do is use antidepressants and psychological interventions because those have been proven to be helpful. And for continued recommendations, one thing that I like that they mentioned was assessing lifestyle factors similar to how we assess vital signs. So collecting this information from the start and considering it, I feel like with a little bit more weight, just the impact that it can have over time. And what I like about this is you can start using this too before somebody has developed the negative health outcomes and start to encourage change earlier. We can also introduce behavioral evaluations and interventions at point of entry for medical or cardiological workup. This is recommended as well, and integrate the teaching of lifestyle medicine. However, there are continued challenges for addressing lifestyle habits and mental health, one of them being the time that people have with their patients. So their last recommendation is to not underestimate the power of small suggestions. Even little things that you drop in your visit can build up over time. So if you use some of these here and there and they only take a minute, over time, it may make a difference. Do people have questions for me?
Is the economic situation of the patient, is that the main driver of this?
That's a good question. I think that is a main driver. Like in research, it's been shown that can be a main driver of problems, and access to good food and access to healthcare, information, health literacy. But I also think that habit too, like people who are not necessarily having experiencing low SES develop poor habits too at a young age. Okay. And these are the conclusions, takeaways from the presentation. Thank you.